Good afternoon, everyone. We'll start with the session. We are a bit, we got the hall also a bit late. Novel therapies for cornea and ocular surface diseases. But who else to start? Chairman Scientific Committee, my teacher, Dr. Namrata Sharma, will be talking on importance of uh, DMF, clinical
DMF.
experience and complicated.
I'll be talking about importance of, can I have the presentation please?
Can you please load the presentation? First one.
Anira. Correct. क्या चक्कर क्या है? तक नहीं है ये. So I'll be talking to you about importance of drug master file, the clinical experience in complicated cases. So क्या हुआ? डायरेक्ट लगा. आप एक काम करो ये We're talking to you about importance of drug master file, clinical experience in complicated cases, and intracameral use. So drug master file was also something which is, which was odd thing which I had also heard for the first time, but I think it makes a lot of sense as far as the drugs, and especially the drugs which are introduced in India is concerned. So generally a doctor's concern would be that you should do the right diagnosis, use the right medication, the right compliance, and also you should know if there are any unknown impurities which are present in the drug or not. So basically this is for the safety, efficacy, and the quality of the drug so that it is maintained. Now, there are a lot of substandard drugs in India, and this is a threat to the medical fraternity and the public health, and we often see the spurious reports which come in press media and newspaper, etc. So what is a drug master file? Drug master file is is basically a confidential document submitted to the FDA, which covers all the comprehensive, accurate, and precise information about active pharmaceutical ingredient. That means the API or the finished product dosage form. That means the FP. So the quality would depend on a lot of things. That is manufacturing, purity or impurity, drug substance, flavor, materials used to prepare drugs, stability of the drug, as well as the packaging material. And it is not only the drug itself which should maintain the quality, but all the other associated procedures as well as the packaging material also, which should also be free of impurities. So the impelling question is that what makes the drug master file a hallmark of purity, safety and efficacy, and I think what we need to look at is the impurities which are present in the drug. So impurities in the drug could be identified or could be unidentified, and they may be present in the drug itself, or they may be in the vehicle, binders, colorant or colorants or diluents. And if present, they only should be allowed above permissible limits, because they should not be allowed above permissible limits. They should be within permissible limits. Then there can be effect of impurities, because these impurities can be harmful. They can reduce therapeutic benefit. They may be incompatible, and they can also change the physical and the chemical properties of the drug. So the recommendations are that while prescribing, one should be aware of the influence of the impurities. Then the pharmacologic perspective should be there, and it should be highly characterized impurity profile for an API which ensures safety and more efficacy for the patients. And then you have a regulatory perspective to it. That means the safer APIs for multi-source products are those that meet the strictest of the regulatory standard. Now, the drug master file, what does it bring to table? Basically, it brings quality, safety, and efficacy of the drug. And there is an investigational new drug application, or a new drug application, or an abbreviated new drug application, which is actually with the FDA. And that is there for every drug. As far as in US it is concerned, it is there with the Federal Drug Association. And this maintains the quality and the safety of the drug, and also gives the highest standard in terms of safety and efficacy. And DMF quality product is the assurance of the superior quality. So such thing should also be present in India, and that is what is being also worked on by the Mankind industry, who are actually working on it, that for every single drug there is a drug master file available, which will look at not only the content of the drug, but also the impurities which are present, and if there are any spurious elements which are present in the drug, which can jeopardize the efficacy of the drug. So this was a study actually which was done on drug master file, the importance and the benefits. There were 2 studies which have been done related to this, and they both, one is published and the other one is going to be published. And it is, what is recommended is that DMF for the drug master file system should be adopted in India also, because of the advantages for the regulatory bottles, the pharmaceutical industries, and ultimately it is going to benefit the patients. And many countries all over the world within the highly regulated markets do rely on the drug master file system. Unfortunately, we don't have it in our country, and so we should ensure the safety and quality of the medicine. Again, this was the study which was done at Vardhaman Mahavir Medical College and Safdarjung Hospital, the effectiveness of the prophylactic intracameral moxifloxacin used drug in cataract surgery by Dr. Narula, and all the patients received injection of 0.05 ml of moxifloxacin immediately after the IOL implant. And the earlier Moxiflox pre-filled syringes were used. Currently, the Moxiflox is available with the international quality, and it is coming as the pre-filled syringe. Hence, they switched from pre-filled syringe to Mahaflox or Moxiflox from the Mankind Pharma, because it was as per the drug regulation by the DMF. And they found that it provides similar efficacy and cost effectiveness, and none of the patient developed any adverse events like TAS and endophthalmitis. And this was the advisory board, which was again done by Mankind Pharma for DMF. And all the panelists in the advisory board, the panelists did feel that DMF is something which should be positively done, and they gave their positive clinical experiences with Mahaflox eye drops or Moxiflox eye drops in the pre or the post cataract surgery, the management of severe ocular infections. So they did conclude that the use of intracameral as far as antibiotics is concerned, the moxifloxacin can be used, especially from the Mankind Industries, for intracameral use. and the development of a sterile pre-filled syringe kit for intracameral use to prevent post-op endophthalmitis, and collaborating with pharmaceutical companies is required to ensure quality and proper packaging. And I think besides intracameral moxifloxacin or besides moxifloxacin, there are a lot of spurious drugs which are available in our country, and they also should be subjected to this DMF, and DMF is something which is needed in our country and should be the way forward. It is one step ahead of the regulation in the sense that after the regulatory board approves it, this also must be a regulatory body wherein the drugs are submitted. So thank you very much for your attention.
Thanks a lot, ma'am, on a very new topic. Definitely this was required in India considering the amount of adverse effects we are having with certain
considering the various spurious drugs which are available by several of our own colleagues, if I may say so, who market these drugs, so the exact, we don't know which regulatory body has approved it, and also the fact that we don't know what impurities are present in it.
Thank you, ma'am. Any questions for madam?
Sir? No, because I know that this topic is very close to your heart.
We have the problem, and I don't know I approached the drug controller of India, talked to him personally. Basically, everybody puts hand like this. We are doing whatever we can. That's all. So,
Thank you, ma'am. Next, also my teacher, a novel nano-silver ion-based self-preservative free technology by Dr. J.S. Titian.
Good afternoon. Thank you, Ilan, for running this important session here. Unfortunately, it is clash with the OPL. And I'm going to talk about something. Yes. We're going to talk about something which is, innovative, and thanks to mankind, which have worked on this particular aspects of preservative-free dispensers. No financial disclosure from my side. Let's talk about the maximum, topical medications today are used for dry eye disease. And it has a huge impact on our society because everywhere in the world, dry eye is one of the leading cause of discomfort and the painful days for many, many people working in different areas. Africa and India has South Asia has the largest amount of people suffering from dry eyes. If you look into prevalence of dry eye disease in India, these are two studies available, one from RP Center, one from LV Prasad, where we're looking for a global estimate of prevalence is around 5 to 33%. But in India, it is from 18 to almost 55%. And mostly, if you look into the difference between India and globally wise, in global area, you have evaporative dry eye or MGD in a huge number, almost 50%. Well, India, it may not be 50%, but still it is a significant number from our side also. So this is the published article from RP Center in IGO, where we looked into a large number of patients coming to our OPD, and we subjected them to OSDI questionnaires. We found almost 32% coming to RP Center OPD had a clinically significant dry eye disease, which you look into, we see almost 5 lakh patients a year, and this is a very significant number of patients having these symptoms, not coming for a dry eye treatment, but coming for other purposes also. And this is a study from LV Prasad, where they looked into the 8 years data of more than 1.4 lakh people, and they found that incidence is almost 1.5%. In there also, the age group, like people, urban residents, professionals, 5th to 6th decade people had a high incidence of a dry eye. And they estimated by 2050, it will be almost 50% people will be suffering from significant dry eye problems, which is almost 2.75 million people. This classification and treatment profile is well described for all of us, how to manage these patients. And you know that step 1, step 2. One thing which is very prominent here is the non-preservative lubricants, because that is what is required for a chronic management. So this was a question I put for my students also. What is the most commonly used ophthalmic solution in for people, they answered artificial tears. It is true that it is very commonly used, and most common one has been CMC for us. Now sodium hyaluronate is getting a #1 position in this category also. So whenever we have to use drug for a longer term, we have to preserve the drug in such a manner where it is not getting infected, because infection is a rare opportunity for bacteria to grow in the dispensers also. Therefore, you need to have innovative devices where either the dispenser will have some sort of controlling the anti-infective organisms by preservatives, or have some sort of a single dose dispensers also. So these are various preservatives which have been used for ocular therapeutic drops. And we all know these preservatives are going to damage ocular surface very, very seriously sometimes, which can cause discomfort, tear film instability early. Later on, it can cause serious inflammation with subconjunctival fibrosis, the epithelial apoptosis, and sometimes the corneal surface impairment, which can ultimately create problem for a patient undergoing various procedures like refractive surgery, corneal surgeries, or a cataract surgery also. Therefore, there is a definite need of a preservative-free medication, especially glaucoma patient, where they have to use lifelong medication, patients on a contact lenses, patients having allergies, or patients who have been using artificial tear for more than 4 drops a day. So these people will definitely require. So there has been a lot of efforts to have a single dose containers. Those are unims, and they are costly, but very difficult to have in the Indian scenario also. Or you have a multi-dose dispenser, which are normally Novelia technique, where they have systems which can be giving 1 drop, and there's some sort of valve action where air can pass through reverse way, and it also has a filter to prevent prevent the bacteria to go inside the bottle also. With this type of manufacturing, the bottle become very hard and difficult to press, and patients do have difficulty, especially older patients. Therefore, there has a need for something which is comfortable to patient and also preserve the medications also. This very novel technique, which is by mankind, is known as a silver nanoion technologies, which is a bactericidal, fungicidal, has a virucidal activity also, effective biologically and non-toxic to the eyes also. And one of the first drop to come is a Lubimois, which is 1% sodium hyaluronate, 0.1%. And this technology, silver ions are in the powder form in the bottle, nozzle, and cap. And that causes bactericidal activity. And there's no side effects onto the ocular surface, non-corrosive. So that is the importance here. So anything which comes in the market, you have to go through this serious, rigorous testing of antimicrobial activity. So they looked into these areas to see if this device can be effective here. So you can see if you have acceptance criteria as 1 log mark reduction at 7 days and 0.3 log mark at 14 days. So this is the challenge of microorganisms, right from gram-negative to a fungus, and it is definitely more than the required log mark values. So this is the second batch. This is the third batch. In all 3 batches, it was very effective to know that it was very effective in decreasing the load of contamination in these cases. It was very safe. Lubimois with this technology also acceptable. The second would to challenge the bottle in terms of safety-wise. The one was in use whole time study, where they opened the bottle 3 times a day and capped, and took a culture at 10 days, 30 days, and 60 days. In second sample, they challenged the device with putting the microorganisms of a significant number, and they also titrated 10 days, 30 days, 60 days. In both the devices, both the techniques, it was very effective in decreasing the load of bacteria in 10 days, 30 days, 60 days, and it is very, very effective in combating the infective agents in these cases also. So if you see that this technique has major advantage in 4 ways. One, it doesn't leach the silver, and it is non-corrosive to the ocular surface, non-toxic to the eyes. Also has a broad spectrum efficacy against all types of microbes. The most important thing is cost effective, which is very useful in Indian scenario. very convenient to patient. If you press it, it is very soft, and at one time it only gives one drop. So it is also very, very, we can say cost effective for our scenario also. In that way, it is a real innovation in terms of a multi-dose dispenser in Indian scenario. I think there is a definite need for us to look into one more area of expanding this device to other areas like anti-glaucoma medication. I think mankind is already working on that. If it works out in anti-glaucoma medications also, that will be very useful in decreasing the costs and getting more compliance for the patients. I think cost and compliance should go together, especially in a disorder where blindness can be prevented. I would say this has been a real good thing for all of us. So this technology definitely needs to be studied for other types of topical medications, if not for antibiotics, definitely for anti-glaucoma medication. Thank you for kind listening, and hope that mankind people are listening and they'll do a better job for future also.
So,
Yeah.
yes.
Yeah, Namrata, you're asking
So
some
I
question?
just wanted to ask, this technology is going to be there for all the bottles? The Novelia kind of...
No, just now, this is a little different from the Novelia technique. This doesn't have a filter inside, the HEPA filter type of thing. And it doesn't have the device where, things can go reverse. That if you have that device, it becomes very, very hard and difficult to press also. This is a device where your silver ions are there in a cap and nozzle, that effectively takes away the antimicrobial load into those areas. So it's like a bottle which is softer. You can squeeze very comfortably, and effective dosing can be there. And I hope that they'll come out with the other areas also.
Sir, my only question is, I think the silver ions are there only at the tip. That's where it is. But there can be some reverse flow after putting the drops. That's quite common.
So it is there inside also. The coating is there, which is also acting for that longer time. But if you combine the HEPA filter and all that technique of Novelia, then it is going to cost at least 3 or 4 times more. So, or effective way to look into a cost effective and also having a prevention of infection also.
Thank you, sir.
Thank you. Yes, it's available freely, and cost I'm not sure, but effective to. How much you said? Okay, 300 रुपया एक पूरे 10 ml के लिए, तो पूरे जो है 3 महीने चलेगा.
Yes.
Thank you so much, and sorry we have to leave you people because we have to be a part of OBL team.
Thank you, sir. Next, we have another great teacher, Dr. KPS Malik. He will be talking to us about results and technique of sutureless, glueless, autoconjunctival graft to prevent recurrence.
Thank you very much, and whosoever are listening anyway, OPL and all those things which are popular with people, they should really not be combined with any other session. That will be my advice, and I'll write to them. And mine is, you must have read it, that this surgery I started or innovated in 2012. And it was published in an index journal, though IGO did not accept it that time. But I think now lots of people tell me that they do it. So it's a autoconjunctival graft for pterygium, and it has definitely reduced in a large way the recurrence of the pterygium. So once you have it's a conjunctival limbal graft, that is limbal cells, which kind of a stem cells or the original cells. So pterygium is a degenerative condition. In fact, I need not to go to details of there are, everything is known about that pterygium surgery does improve the curvature, the refractive error, the vision, everything. So I don't need not to go to that. I will just show you the film really. And it is a very prevalent condition, and I keep on telling that in Thailand I have seen that virtually everyone has got a pterygium in the nasal and temporal. And they have the large camps for pterygium surgery and they just keep on cutting, nurses keep on cutting the pterygium and throwing it like a chicken neck. But the chicken is murdered like this. So they have that much pterygium. But we also have in North India quite a bit. It is, it's still not that much in South. But at least in Rajasthan, Delhi and Haryana and Punjab, this is quite still a problem. And pathogenesis, again, I would not waste my treatment was done with mitomycin and the conjunctival autograph has changed it and a lot of people doing it and then but you're using the either glue or sutures. So this surgery which I started and lots of people do follow it, they feel difficulty, but I think if it is properly done with the patience and giving time of few minutes, this will hold. The conjunctival graft without sutures, without glue will hold. So I will just show you the surgery in fact. So basically it is a conjunctiva pterygium is cut away from the area and then you bring the graft from the superior limbus to the where the graft was to prepare, where graft is to put, and length and width, the graft you take 2 millimeter more than the area. The area is suppose 5-7, then you must have the 7-9 kind of the graft. Because the shrinkage of the graft, take that into account that you take 2 millimeter more, the donor area. I hope this works. So this is the surgery and I think nothing to comment about it. You can see and understand it. It is of course a grade 1 pterygium beginning only, but it is, in fact, pterygium, longer it goes into the cornea, it leaves the marks and leaves it for long time. So here we are separating the conjunctiva, pterygium, and I use the crescent knife to separate it and then go up and down, see that even the smallest margin of the pterygium must be separated. Though it was looking very small, but see when I have cut through, then you will find a lot of bare area. So a lot of vertical and a lot of horizontal bare area. Other thing about pterygium is that subconjunctival tissue is the pathogenic, kind of it is pathological, it's not normal. So once you have to excise the subconjunctival tissue also from this conjunctival area where the pterygium was. The pterygium cover, you can preserve the lot of conjunctiva, but the conjunctiva which was really involved in the pterygium formation should be excised so that you have a real fresh conjunctiva as a graft. See, this is separation of the subconjunctival tissue. So I am holding the conjunctiva with a toothless forceps and then separate it from the conjunctiva. And you excise the subconjunctival tissue which is supposed to be pathological. This is, if you do the histology of this one, it is not a healthy part of the conjunctiva or subconjunctival tissue. So it is a subconjunctival tissue, and you can see now that graph, the area, the bare area will much more than was seen when we started running the video that the pterygium looked so small. See now, so measure it vertical length and measure its horizontal length and then inject the subconjunctival jarlocaine, maybe 1%, 2% with adaline, so that minimum bleeding, and make it so thin that conjunctiva, virtually epithelium is lifted up, that not the full thickness conjunctiva. So thinner the graft, better the result. So you have to, so this is the area I have inflated with a, so you can do it under the local also, topical also, but I will prefer that since patient cooperation is required, so retrobulbar or peribulbar injection is good. So patient cooperation is not that much required. So the eye is stable, and then you make a mark, and then start separating the graft area horizontally and vertically, and it should be larger than the bare area which you have measured. And here also that advice is that have the thinnest possible conjunctiva, because we generally don't put suture here. This heals itself. The area from which we have taken this graft, it heals within few days, and you will see next day also many times. Lately I am putting one suture also, limbus and this conjunctiva, and then it virtually fills up very fast. But since we are making it sutureless anything, so if you don't put the suture anything, it really doesn't make a difference. Only thing is that this graft should not be very deep or very thick. It has to be very superficial. It has to be virtually very thin conjunctiva. And then you go in the limbus to dissect the limbal area also, because it is presumed that limbus has those so-called stem cells which makes the fresh cornea or fresh conjunctiva. So we will dissect I'm going deeper into the limbal area and even dissecting a bit of deeper limbal and deeper conjunctival tissue, the corneal tissue. So this is again a patient must dissect into the limbus so that you get really limbal cell, and so we call it conjunctivo-limbal graft, not the autoconjunctiva, but it's a conjunctivo-limbal graft, that you must have the limbal cells also, so-called stem cells of this area, conjunctiva and cornea. You have to guard for the surface, that is, which has to go down onto the area where you are grafting it. You can make a mistake, that if you put it upside down, then there will be problem. You virtually have to redo it. So see, just simply put it there where you removed the pterygium, and put it in place gently with a iris repositor or a earbud or anything. Question is, there have been technique described where they break the vessels to make the hemorrhage there. That hemorrhage means that it will hold the graft. But I have felt that initially I tried that, but once you have blood under the flap, it tends to get lifted up. So not required at all. In fact, nothing is required at all. Conjunctiva, as soon as it gets attached to its sister cell, it starts secreting the fibrin of its own. So it will be just held up like this, and I keep the bandage. Initially I used to do bandage for more than 24 hours, but now 24 hours, like if I did today 11 a.m., then next day 11 a.m., I'll open the bandage, and this will be fine. Everything is absolute intact. So you have to start with something like Moxi LP, loteprednol, and moxifloxacin 3 times a day. So this will hold it. And the loteprednol means that no edema, that edema of the graft should not occur. So initial phase is likelihood, so we have to give the steroids, but low dose, not the high dose steroids. So these are so many the studies done by my PG, and she has done really extensive about astigmatism and vision improvement, and so these surgeries are done in time. They give a very good result to the patient. So these are patients like preoperative, postoperative day, 1 week later, left eye, all these are 6 weeks, 12 weeks. So see that 12 weeks you hardly can make out that there was a graft done. It's virtually absolute normal conjunctiva, no trace of pterygium at all. And no opacity also. If you do it really early, that it is just crossed the limbus, then even if it is 2-3 millimeters, you would generally not find a mark, because this limbus cell will repair the corneal tissue also, that area. So generally opacity is left when it's really penetrated deeper than Bowman membrane, and it goes towards pupillary area. So this is right eye, and again pre-op, post-op, 1 week, 6 weeks, and 12 weeks again you can see that is the absolute normal conjunctiva. 6 weeks also is a normal conjunctiva. So try it, and it's really right eye, patient 3, right eye, pre-op, second day, and see 1 week later. But here opacity will be left because it has gone quite a bit and it has got quite deep also. So it would leave the opacity. But opacity tend to get thinner over the time. Since we have put this limbal graft, this does help the even repair of this tissue. So in this study, of course, with till 2 years, no recurrence of any kind. And I think this surgery need to be learned by all young people. And believe it that it is possible to do it without glue and without sutures. And glue, of course, has its own drawbacks of like carrying the mad cow disease and HIV and so many other viral things. So no glue is safe as such, and it is it can produce the immunogenic reaction also. So I prefer this one, that no glue, no suture. Suture, of course, if you are in kind of that not very sure, you can give not all sutures so many around. You can give one there, one here, one there. Just 2 or 3 sutures will do, because it just gets caught very soon with the neighboring conjunctiva. So you can do initially with few sutures, maybe 2, one upper, one lower, and third on the nasal side. But after few surgery, you will feel that you can do it without that. So these are the study done by this girl, and so many of them followed for a long time, and they are good. So thank you very much. I think you can do this surgery, all can be done. Thank you very much.
Hello. Thank you so much, sir. Sir, have you tried this in recurrent pterygiums also? Like if the pterygium is
yes, recurrent pterygium also we do, but that is little efforts are more, and you have to be careful that if somebody has done it 3 times or 2 times, be careful that you are not perforating the sclera or limbus or cornea. That is the tricky part about recurrence. If you have got really recurrent, I did just 10 days back. I don't have the photo of that lady. It was done 3 times at Gorakhpur Medical College. 3 times, and this lady has a thick one, in fact, very bad looking, but after this grafting, everything, she's absolutely fine after now, more than a month now. So in recurrent also you do, but recurrent dissection has to be very careful, because there are fibrosis and adhesions, and you can have a perforation. So that should be avoided. It is very well known that residents, if are not supervised in pterygium surgery, you can have the deep cut in the sclera or cornea. The complication of perforation are reported.
Yeah. Thank you so much, sir. Now I would like to invite chairperson of the session, Dr. Ilan Kumaran, sir, for management of OSD with cataract.
Thank you, sir. Can you have the slides, please? At the outset, I'd like to thank the scientific committee for giving me this opportunity. Why should we ever, say 20 years back, we were not even discussing about dry eye in cataract surgery. Now look at this particular study where all dry eyes can happen anytime, dry eyes can happen anytime, starts immediately after cataract surgery and increases, peaks at around 1 week, stays for around 4 to 6 weeks, and then reduces. Why should we even bother about a dry eye in such a situation is the question, but this is the answer. Because almost 87% here and 85% of people here presenting for cataract surgery have subclinical dry eye. They don't know. And after we operate, come after 6 weeks and keep complaining about it. Hence, a surgical society, ACRS, finally gave a survey to its participants and asked, what do you want from this? This was the answer. We have a lot of studies, but it is confusing. Too much of data is there. We don't know what to do. Hence, ACRS decided to start a committee to come out with a report and prepare an algorithm what should be done in cataract surgery if the patient has dry eye, or how to prevent dry eye after cataract surgery. Now, any algorithm should be consensus based, it can be incorporated easily into practice, reduce the chair time of the surgeon, and most importantly, in this case, we should be able to classify it visually significant or not. We would have done an exceptionally good surgery, but thanks to the dry eye, our IOL power would have gone erratic because of the changed keratometer reading. Even if you put the top of the IOL, because of dry eye, he'll have poor quality, and there is a higher chance of infection in these cases. Hence, what are the things to do? Pre-operative, intraoperative, post-operative, and the treatment. That's how I've classified this particular talk. So this was the algorithm that was proposed. Now this is what, in short, it's a non-invasive surgery planning, and if necessary, a possible repeat is required. Most important part of this algorithm was this: it's idiot-proof. Even your receptionist, even probably watchman, if you can train, can do this. It also says where to start and where to end. It says start here. The point to be noted here, if at all, if you have touch the patient, put paracaine or touch the patient, wait for 2 hours before you start these readings. And the first thing what you do is take the readings of the IOL power. That's what is the first thing to do. Then you give a questionnaire, and in the questionnaire, also, while taking these readings, teach the optometrist to look for these kind of findings. Any inferior steepening which cannot be explained, or any distortion of the Mayas indicate dry eye. Give a questionnaire to the patient. What was used here was the speed questionnaire, which they had modified and called it speed 2, wherein they had just added these questions related to the cataract surgery, whether the patient is willing for multifocal advanced IOLs, whether he can pay out of pocket. This is effectively the speed questionnaire with this modification, and then subject the patient to examination. Examination, they said you do osmolarity, you do MMP, all these kind of things. We don't have access to it. So what I do in my practice is look for the aqueous volume height, tear volume height, less than 0.1, 0.1 to 0.25, above 0.25. 0.1 to 0.25, approximately in the mind we can make out that is normal. Anything below or above is abnormal. Even with a simple AR, we can look at this, do work as a mybographer, look at the meibomian glands, and then proceed, decide on the patient. Of importance, LLPP, look, lift, pull, push. Look out for any abnormalities of the gland, of the eyelid margins, and then decide whether this patient has dry eye or not. Now, after deciding whether this patient has dry eye, we should find out whether it's visually significant or not. Now, visually significant, I teach my optometrists, what do I tell them? If a person after a blink, if that keratometry changes by more than 0.5, then this is significant. Ideally, it's 0.1, but 0.1 we can't measure, so 0.5, this is significant. This is what I teach them, and they look out for that. And if there is any staining, finally stain this patient, this is a visually significant where you have to treat this patient. If these 2 points are there, then defer the cataract surgery, treat the patient for dry eye, and then take him off. If it is not there directly, you can go ahead with the cataract surgery. How long to defer? 4 to 6 weeks. Point to be noted here, be very careful. If you leave it for 4 to 6 weeks, it will go to the next clinic. But then please explain to the patient and then go ahead with the surgery. This is the algorithm. Intraoperatively, we all know why we get dry eyes. Dry eye, we are traumatizing the nerves. So try to reduce this nerve damage. The 2 millimeter incisions are best in these cases. And during the surgery, reduce the ocular trauma. Do not catch hold of the conjunctiva, pull, push, tear the conjunctiva. Reduce the repeated drying and irrigation. This is another thing which we miss out. Reduce the number of preoperative drops. We put a lot of anesthetic drops. Reduce the time that is taken so that the phototoxicity is reduced, and of course the surgical trauma. Post-operatively, what do we do with these patients? What is the regimen that is prescribed? Now, this is a study wherein they classify the patients into these 4 groups. Group A, only steroid antibiotic combination. Here it was tobramycin and dexamethasone which was used, not any of our advanced things. Group B, they added a mydriatic. Now, that we do not do in most of our phacoemulsification cases. Group C, they added NSAID, Nepafenac, and group D, they added carboxymethyl cellulose. Simply said, just look at this group D. Always it was performing better as regards the Schirmer and BUT, as well as the patient's response to pain, least pain in the group 4. Most of the other things also recovered towards after 6 weeks, but the initial period, adding a lubricating drop is best thing to do with cataract surgeries. Now comes the question, cyclosporin or not immediately. Now look at the study. It says that cyclosporin, if used, is definitely better, but then what do practically we do? If there is dry eye, then we use it preoperatively at least 4 weeks before and continue for 6 months after cataract surgery. something which has been lingering on your minds during our ECCE days or the early part of phaco days, dexamethasone we were using and we never had dry eyes. That's what we thought. But then again, there's a study to prove because prednisolone has more incidence of dry eye when compared to dexamethasone. However, dexamethasone alone is not enough. Only now we are not getting it. So dexamethasone is the preferred drug over prednisolone acetate. Use of NSAID, if possible, avoid it. Do not use it for all of them. And if you have to use it, use the single dose or the 2 times a day, such as nepafenac or brownfenac, which is once or twice a day. And even if there is a slightest doubt, refer to the corneal surgeon, because melting is seen in these kind of cases. Very novel thing which says ocular surface frailty index. Initially, they looked at these 19 different parameters and said which is the best correlation. Later found these 10 parameters. I'm not going into complete detail because this itself will take 15 minutes. These 10 features are what predisposes a patient to dry eye. So if he has any of this, look at this patient with concern. And what they said was this value, 0.3, 0.25 to 0.3, they took as a cutoff. If OSFI is more than 0.25, 0.3, they said treat this patient vigorously before taking up. As regards treatment, we know what DUSE 2 says. Let's not too much into it. Only thing, it is look for symptoms. If there are no signs, look for symptoms. Be aggressive with the treatment. And only point which I would like to say, follow this nomogram, but if the patient is even grade 2, I would like to initiate grade 1, here I'd like to initiate grade 2 treatment, that is 1 step above. Normally, whatever we do 1 step above for these kind of patients. These are the algorithms to use. Now comes 2 questions. I am a clinician. I don't have access to all these things. What do I do? Asia Pacific Dry Eye Society has proposed very well, wherein they have classified the staining patterns into area line, random, and spot or dimple. Based on this, you can make your diagnosis, because aqueous deficients are more prone to more dry eyes after surgery. So here, if you look at it, these random breaks, these are the commonest which is found in evaporative type. This area break or the line break, simple staining can give you these results. These are found in aqueous. If you find any of these two, treat aggressively. And more importantly, if you find something like this, which we find very, very rarely, I have not seen much, in these kind of cases, it's a wettability issue. That is also a significant issue. So random break, you can ignore. They also suggested use of these 2 drugs, which we have used and not found to be very thing. Summing up the treatment, it is use not just the lubricating drops, immune modulators, steroids, NSAID, go aggressively with punctal occlusion, which many of us are not doing nowadays, but it's very good. If need be, if it is meibomian gland thing, use tetracyclines or macroglides. Now, final question. I'm a clinician. What should I use? In all these cases, of course, it's multifactorial. All these cases, the commonest thing is a lubricant. So let's concentrate on what to use for this. I've got this study. There are multiple other studies. These are called multi-actions. Cause for dry eyes, it has been listed there. Tear film stabilization, corneal epithelial, cytoprotective action, increased mucin accretion. If you look at all these things, it's only serum which acts everywhere else. And the only other drug which acts is, that is hyaluronic acid, which is marked top. But the CMC with trehalose, if CMC is combined with trehalose, it can give the similar kind of action. Just last 2 slides. And this slide also reiterates that when you look at actions, it's better to use a multi-acting drug. And look at here, now, CMC, HA, CMC, HA, but CMC, HA, but this is where it scores. So hyaluronic acid is more of a multi-action drug, and that would be my preferred choice in treating dry eyes with cataract surgery. Thank you for the opportunity.
Thank you so much, sir, for excellent presentation. Sir, do you think like the incisions which we used to do 10 years back, like 2.8 incisions, and now we have shifted to 2.2 incisions, does it has any effect on your like patients of dryness?
Definitely, sir. The smaller incisions have lesser incidence of dry eye. Not only this, the superior incisions again have a slightly lesser incidence of dry eye. And third very important thing is shelved incision, which we do 3 planar incisions, have more incidence of dry eye than a uniplanar incisions.
Okay. And second thing, like before doing keratometry, do you like dilatation of the patient occurs after doing the keratometry?
That is one fallacy, sir. So if I diagnose a patient with the cataract, I get the cataract investigations done based on his vision itself. Based on the vision and the refractive readings, I get it done, then dilate this patient. If a drop is put, we have to wait for 2 hours before initiate.
Thank you, sir.
Thank you. Sir, thank you. We started half an hour late, sir.
I can understand. Thank you. It was a wonderful talk.